Hello and welcome to the Pharmacy Informatics Professor 2020 with your host, Dr. Armin Simonian. In the last episode, episode 9, we talked about clinical decision support and gave some definitions. And as promised, this is episode 10, which takes a deeper dive into some of the specific areas of clinical decision support. So with that, let's get started with a presentation and get right into talking about some specific tools with clinical decision support. So as we know, there are three components to CDS. That's the knowledge-based inference engine and communication mechanism. And as a pharmacy informaticist, you need to realize that the information in these systems is usually vendor supplied. So we have to have a good working relationship with our EHR vendors to make sure that our pharmacists are getting the proper tools, CDS tools, to help with their review of orders, and that the prescribers are seeing the proper alerts during prescribing. CDS categories that we discussed last time are passive and active, and during this video I'll focus in on some of the active interruptive CDS. With medication administration, we have the 5 rights: giving the right drug to the right patient in the right dose, at the right time, by the right route. We also have 5 rights for CDS. We want to make sure that we're giving the right information to the right person in the right format, through the right channel, in the right time in the workflow. If we don't follow the 5 rights of CDS, we end up with something called alert fatigue, which I mentioned in the last episode. Here's a definition: a state of irritability, exhaustion, or bewilderment triggered in clinicians who have been exposed to too many alerts, or alerts with a perceived history of irrelevance, which cause the user to ignore some or all of the alerts, thereby reducing the safety benefit of the decision support system. So alert fatigue can negate all of the positive aspects of clinical decision support. So we do want safer and more effective prescribing. And so to do that, we want to minimize alert fatigue when we're using CDS tools. Let's focus in on allergy checking, drug-drug interaction checking, and rules. So here's a pop quiz. What is the overall average percentage of cross-allergenicity between penicillins and cephalosporins? Way back when in school, I learned that it could be between 5 and 15%. And in reality, what we're seeing, according to the study, is a much lower percentage, maybe 1%, and with patients with a confirmed penicillin allergy, up to 2.5%. And really, the bothersome cephalosporins are the ones in the first generation and some of the second generation. If it's a lot of the second generation, third or fourth generation, there's no appreciable cross-allergenicity. So the system should not warn of those. And that's one of the issues with the current programming within our systems. Another thing that we see is something like coding allergy. So what we find is that a patient will have a side effect of GI upset. It's not really an allergic reaction, but it'll get flagged as an alert, as an allergy, and then every time a prescriber orders any opioid, you're going to get that warning. So we know that a true allergy is immune-mediated. So if it's a pseudo-allergy, you do get some histamine release and some symptoms of hives, but you don't have the true allergy symptoms or side effects or adverse effects such as bronchospasm, angioedema, severe skin reactions, and severe hypotension. So really in our systems, we want to make sure and document allergies properly and really identify the true allergies, not the pseudo-allergies and not the side effects or intolerances. Our systems do all or none alerting, and that's the problem because in the example of penicillin and cephalosporins, anytime any penicillin or cephalosporin is ordered for a patient, if there's a penicillin allergy or cephalosporin allergy documented, then it will warn for any penicillin or cephalosporin. And there's no logic for considering allergy status, severity, and intolerance. So if we flag it as a pharmacist, we interview the patient, we find out it was an intolerance, the system still warns. Allergy documentation is really important. We want to make sure that the correct allergen is selected when documenting allergies for our patients, that it's coded, and that we're ranking and statusing those allergies. Some of the strategies for reducing alert fatigue are to make sure that you have some kind of policy and procedure in place so that the appropriate clinician is documenting those allergies, and then you want to make sure that there's compliance and quality assurance with that policy and procedure. And then as pharmacy informaticists, we can work with our vendors to customize alerts at the drug level versus just warning as a class level. We also want the logic of the EHR to take into account allergy status or severity ranking and intolerances. We want to employ real-time push-button data analytics to make sure that we're doing things properly within our system, and then establish some tools for monitoring, such as a daily allergy report or a compliance report. So here's another pop quiz on a book that we probably all have seen, Hansen and Horn's Top 100 Interactions. And we all know that there are thousands, maybe 10,000 drug-drug interactions, but the authors of the book really emphasize that there is kind of a top 100 or so where it's really important to follow up on the drug-drug interaction in terms of therapy. There are 5 classes mentioned in terms of drug-drug interactions. So the contraindications, severe contraindications, the things to avoid are class 1. And then changing therapy, avoiding therapy is a class 2, and also class 3, minimizing the risk by considering alternatives. These are the ones that are the most important for clinicians to see. You don't want to alert on your system on all 5 classes because you will get a lot of nuisance alerts. Low specificity and high sensitivity can lead to a lot of inappropriate alerting with drug-drug interactions. So what do we want to do? We only want to alert when there's a truly significant interaction. And for your prescribers, for your providers, maybe you want to only alert on class 1 and 2, and maybe for your pharmacist reviewing the order, alert on class 1, 2, and 3 drug interactions to minimize the pop-up warnings when reviewing those orders. Another exercise that you might do, which is quite labor-intensive but worth the time, is to review every single interacting pair on your system, and then based on evidence, based on research, either promote or demote those interacting pairs. In other words, if something is listed by the knowledge base vendor as a class 1, but you know that it's not a true contraindicated pair, then you can push that down to a class 2 and reduce some of the alerting, or even push a class 2 down to a class 3. We talked about rules in a previous episode, and we went through a rule example programmed for an influenza vaccine. A good programming language to know for a pharmacy informaticist, if you are going to study a programming language, is structured query language, or SQL or SQL. And the reason that I show this one is that a lot of our EHR vendors use SQL to program rules and reports and labels, and so it can be very useful for the pharmacy informaticist to know SQL. And with rules, we want to establish a process for requesting, deploying, and monitoring the rules. When you write a rule, it's not just writing it, programming it, but you have to make sure that it works within the databases within your EHR system. Then you have to test it out in the non-live environment, let everybody know that it's coming, implement it, monitor it to make sure that it's firing properly, and then study it to see if it's being effective. And then when it's done and you've solved the issue, then you can inactivate the rule. Rules can slow down your system, so you don't want to have thousands of rules running at the same time. If you don't need the rule, shut it off. In summary, our big challenge with CDS is alert fatigue. And hopefully you've gotten a better idea of some of the specific types of active interruptive alerts and what to do to hopefully reduce that alert fatigue. So we want to work with our EHR vendor to improve CDS functionality, ensure accurate documentation within the patient records. So here I'm really referring to allergy documentation. And then using research, evidence-based medicine to improve our knowledge bases, formalize the process for rule implementation, and then we really want to use data analytics, analyze the data, make sure that there's data integrity within our systems, alert compliance, and that we're helping with improving medication therapy outcomes. Hopefully this gave you a better idea of CDS and what it's all about, and some of the things, activities that a pharmacy informaticist might do to improve these systems. So if you found this video useful, please like the video and subscribe to my channel. I'll thank you for that. And in the meantime, stay safe, stay healthy, look after the health of others, and I'll start working on the next episode. See you next time. Take care.